Conference will now be recorded.
There we go. Hello, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Tuesday, October 28, 2025. I'm Len Sierra, and I'll be moderating today with a little help from my fellow moderators, John and Rick, and all of you well-informed attendees. Keep us on our toes. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. And we want to acknowledge and thank our sponsors. They are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. All right, so first person on my list is Craig Christensen. So go ahead, Craig.
Okay. So let's see. I attended about a year ago with some questions about my high Decipher score and Decipher grid data that said that my cancer was perhaps neuroendocrine-like. In the ensuing year, actually, my PSA has risen rather slowly with a doubling time of about 17 months to 0.12 at this point. So I'm getting into recurrence territory. And I had a couple of questions here.
Craig, what was your primary therapy? Your first therapy?
Surgery in 2020.
And that's it?
And that's it.
No hormonal therapy, no salvage radiation. Okay.
Correct.
And what was your Gleason score?
7, 4 plus 3.
And 2020. All right, go ahead.
2020. No other outstanding issues on the pathology. Prostate or Decipher was 0.81 in the high area. My first question is about seeing docs at different centers, the logistics of that. I am moving towards spending more time in San Diego, moving from Colorado, and I'm interested to have my cancer care there at UC.
Are you hearing it?
But as I anticipate either salvage radiation or metastasis directed therapy radiation, I might be interested in an MRI guided machine, such as is available at UCLA or City of Hope in Irvine. So a ways away from San Diego. But my question is, if I start with a rad-onc at UCSD to get started, perhaps to get a PSMA PET scan, is it going to be awkward or difficult to, if then I want to get radiation treatment at either City of Hope or UCLA? And eventually, I know that this group thinks highly of Dr. Rana McKay at UCSD. But I don't know if it's appropriate to try to get her on my team at this stage. So
who's your current medical oncologist?
I don't really have one in Colorado. I've sort of been tracking my PSA over the last 5 years.
Okay. So what was your concern about the PSMA PET? That should be approved at 0.12 nowadays. They seem to approve it at 0.1.
Yeah, I don't have a concern about that. My question is, if I establish care with, for example, Tyler Siebert, rad-onc at UCSD, if I start with him, is it going to be difficult if I want to get radiation treatment not at UCSD in order to get the MRI guided?
I don't believe so. I don't know, John or Rick, what do you think?
Well, Craig and I kicked this around just very briefly yesterday, and I opined that I thought it might be a little awkward, but should really go smoothly. Nobody should mind him picking and choosing his doctors at different institutions. They may not talk to each other as smoothly as doctors used to in the old days, but communications can go through Craig. And I thought that if he wanted to do it, he should try to make it happen. And if they threw obstacles in his way, we would work our way around those obstacles. I don't think they should throw big obstacles in his way.
Okay. Should I try to get on board with Ronna McKay at this stage, which is really pre-radiation treatment, or do I wait till later?
I mean, I think, I don't think you should anticipate your treatment. I think you should establish that you have recurrence first. And then when you establish you have recurrence, then you decide how you're going to treat. And I think that you can probably establish recurrence with a GU medical oncologist. Depending on who you want to go to, I mean, I think there are more, and we could give you other names, but I think either we would say Ronna McKay at UCSD, Tanya Dorf at City of Hope, or Matt Rettig at UCLA. If you think that you're going to be spending most of your time at UCSD, I would say, yeah, choose Ronna McKay, and then if there's a type of radiation that you feel is appropriate that you cannot get at UCSD, then you can talk with her about where to go, but still use her as your quarterback. And I would say that would be, that'd be true of the other two. We like all three of them. I'm a little bit concerned. I don't want to say concerned, but I would say that Tanya Dorf does have a tendency to move people into trials more than the other two do. But that said, all three are good. So you have to decide where you're going to be and who you want, and then start working with them. I mean, it might turn out that they don't see anything. 0.12 can be a little low to see anything on a PSMA scan. Also, bear in mind that 20% of men don't even show anything on a PSMA scan. So just because you don't see anything on a PSMA scan doesn't mean there isn't anything there. And a lot of docs seem to forget that. I don't think any of those three would, but they do. And then, yeah, you could be a good candidate for metastasis directed therapy, given on how slowly your PSA is rising. If we see something, yeah, metastasis directed therapy is a good option. So that's my 2 cents for whatever it's worth.
Thank you, Rick. Appreciate that. Any thoughts on the metastasis directed therapy timing? I mean, I know Mark Schultz says these days, well, maybe give it a little bit of time to show up on PSMA. And other docs say, well, if you see a trend, you should treat.
Yeah, maybe Len or John will remember, but there seems to be no difference in waiting on salvage therapy over the first year. But you're so far out, you're 5 or 6 years past that it's not so much a question of shall we just wait, which is really what I think is what's on Schultz's mind. That people shouldn't dive into metastasis directed therapy right away, but you're so far out anyway. And I think that that's probably where choosing your quarterback is important. You know, I know, I don't know enough about Rana Mackay at this early stage to sort of know how she would go. I do know that if there's a trial that fits somebody like you, Dr. Dorff will certainly be presenting that trial to you. And I get the feeling that Dr. Reddig is patient. That's just a gut. You know, we've got at least one Dr. Reddig person in this call today, and I can't say for the other two docs because I can't recall, but they're all good docs. So that's where, what do we think about metastasis directed therapy? You know, it's just to me, it's just a fancy term for spot radiation. I mean, that's what we used to call it. That's what Dr. Paul always used to call it, spot radiation. The question was, when do we do the spot radiation? Maybe we should ask Dr. Paul what he thinks.
Well, thank you. I think avoiding ADT, androgen deprivation therapy, for as long as reasonable is reasonable. And I think the spot radiation metastases directed therapy, if you have such a target, can delay ADT. And I don't think delaying it until whether you receive it now or with a PSA doubling time that you said of 18 months or a year from now, carefully monitoring, obviously, its progression isn't going to make a big difference in eventual outcome. So I guess I would be slow to pull triggers, and that's just one side of the equation. But there are many different thoughts on it, as you hear, and no definitive answer.
All sound advice, seems to me. Craig, what do you think? Any other
I
questions?
think that's great. I appreciate it very much. Any tests that I should do, like Prostox or Artera AI, or any others?
These are really tests that people do before they're treated. Those are not typically tests that will be done for. I mean, maybe the AI, the Entera AI, but usually that's to see if you should get hormone therapy with your first round of treatment. I wouldn't think of either of those tests as being tests that are common on recurrence. That's my gut. What do other people think about that?
You guys might remember that Craig was the guy that introduced us to the grid test on Decipher. And
yes,
we debated back and forth what to make of this idea that he had neuroendocrine potential on his grid test. And I'm glad that it didn't push anybody into treatment, because it's been a pretty indolent process ever since back then. I think that a PSA and then maybe a PET scan should be enough information to make a decision about the next phase in treatment. I don't think that that there will be a need for more diagnostic information at that point. We'll have to see. Prostoc sometimes is good at saying whether you should have SBRT or EBRT, but like Rick says, this is a test that was standardized on people much earlier in treatment. And he doesn't have a prostate anymore.
Right.
So it's not going to really be EBRT unless the PET scan finds lesions in the pelvis. We were talking the other day about whether to try to get a PET scan now or wait until the PSA hits 0.2. I know my doc would wait, but I know some other docs would go ahead and get further information now, even though there's a risk of a false negative. Do you guys have any opinion about whether he said he was going to get another PSA test quite soon, I think.
When was your last one, Craig?
2.5 months ago.
Yeah. Well, of course, if you get the PSMA PET and it doesn't show anything, then you don't have to think about MDT because there's nothing to target, right? And so at that point, if it were me, I'd be thinking, well, I have a very slow doubling time. That scan isn't showing anything. Why should I do anything? I would wait, let it get higher. And then you could always do another PET scan, like John said.
Okay, thanks for, yeah, sorry.
It sounds like, this is Henry. I guess I'm in somewhat a similar situation. I 0.12, I had a PET scan, PSMA scan, and actually it didn't show anything. And the doctor wanted to give me the PSMA PET scan anyway, but I don't think it was high enough to show anything. I think you really got to wait maybe 0.2 and above, maybe.
Yeah. And Henry, it's a good period of time. How long is it since your RP? I know it's not as long as Craig, but it's
going on 3 years. It'll be 3 years in a couple of months. Yeah.
Right. I think
Dr.
you guys.
I was just going to say that regarding the PSMA sensitivity, Dr. Schultz has an interesting rule of thumb, which is whatever the decimal of the PSA test is, more or less translates to the percent probability of getting a positive PSMA. So in other words, at 0.12, it would be 12% chance of seeing something. At 0.5, it would be 50% chance. It's an interesting rule of thumb.
Yeah. But we have plenty of experience in this group where that just doesn't apply at all.
Yeah.
You know, some guys can have a PSA in the 20s and the PET scan shows nothing.
Yeah.
They can have a PSA of 0.1 and show several metastases. So you have to be careful about these nip and tuck rules.
Yeah, definitely agree with that.
Yeah.
Len, I'd just like to say thanks for all the advice. I realize that I'm kind of knocking on the door for this group in the early stage that I'm at, but I do appreciate the advice.
No, I want to, Craig, you're very welcome. You're not, as you hear from Henry, you're not the only one. Henry's been attending this group. We have other gents like you, and you know, we feel privileged to be able to help some of you guys who are looking at early recurrence. I mean, sadly, I think the biggest issue for early recurrence is much like we find in our active surveillance group, which is we need to do a better job on anxiety management.
Mm.
I think, and maybe I'll let Dr. John say a word on this, because it's definitely very much in his wheelhouse. But I think it's the anxiety management that is the challenge in a situation like yours or in a situation like Henry's. John, what do you have anything to say on that?
Well, Craig, I think, is doing a good job of finding that happy medium of having just enough anxiety to make him do a good job of taking care of himself, but not enough anxiety to wreck his happiness or keep him away at night. Once you cross the line into your anxiety keeping you awake or messing up your daytime happiness, then you have to do something about it, and keep talking to us about it all the way along as well. Do you have I can't remember from last year, social support, close friends, married, anything like that?
I have a spouse, yes.
Okay.
And I appreciate Dr. John and my partners kind of talking me back from the ledge a year ago when I was freaking out about the high decipher. So a good point, Rick and Dr. John, about anxiety and trying to achieve the balance. And this group has been essential for me in that regard. I have not attended live, but I'm a lurker. I watch all the videos. So.
Well, that's okay. And feel free to come into Men Speaking Freely, because that is a great surprise to a lot of people who have never been in there before, or they think, oh, I don't need that. In fact, we have one of our key people, volunteers, moderators, who tried his hand at Men Speaking Freely recently. Would that person like to make a quick testimonial or not?
we don't name names here.
We don't name names, but you can volunteer, Len.
Yeah, it looks like I've been volunteered, and so am I to promote Men Speaking Freely for Craig? Is that what you're looking for?
I'm sold.
Is just no, because John can promote it, but it would be good to share your first experience, and because you didn't go, we couldn't get you in there forever, and you went in, and we really didn't bite your hand off, did we?
No, very welcoming, a very rich, rewarding experience, Craig. I'm glad I did it, and I'll probably do it again this Thursday. I think if the meeting is on, I think it's once every 2 weeks. Yeah, nothing to fear there. All very nice, compassionate, welcoming guys. So
yeah,
do feel free to attend.
Thank you. I think I'm good, Len. Thanks for all the time and comments from everyone.
Sure, thank you. Keep coming back. I have next Steve T. in Wisconsin. Go ahead, Stephen.
Thank you, Len, and hello, everyone. I'd like to thank the group for your support since I was diagnosed in February of this year with a PSA of 9.52 and a Gleason score of 4 + 5 = 9. I'm 3 months out from my prostatectomy. I had a PSA test last week and it's less than 0.01. And I'm scheduled to see my surgeon for a 3-month follow-up this week. And I'm just wondering if there are any questions I should be sure to ask him.
So you had the prostatectomy, you're a Gleason 9. I presume they put you on hormonal therapy?
No, they did not put me on hormonal therapy.
So you had nothing but the surgery, and that brought your PSA down to 0.01.
No,
Yes.
it was the RP that did that, wasn't it?
Yeah, the surgery.
Yeah, just the surgery alone. Yeah,
Yeah. Wow, that's
brought him down
fantastic.
undetected. Yeah.
Hmm. And how you said? Did you say February?
Yeah, February I was diagnosed
Right.
and had the
Well,
surgery in late July.
that is remarkable, I think. Um, what questions could you ask your doctor? Well,
Steve
you
also
plan on
had cribiform and intraductal, I think, on his biopsy, if that guides you in any way, Len.
John, sorry, no, I did not have crib reform or introductal.
Okay, thank you. I'll correct my data here.
I mean, other than making sure that you follow up every 3 months or even every 6 weeks, if you don't like waiting every 3 months, you can request that he schedule your PSAs for every 6 weeks. I see Bob McHugh is asking, he's curious to know who did the surgery.
Is it Dr. David Gerard at, I think he's with the Carbone Cancer Center. That's at UW, University of Wisconsin-Madison.
Right. Anyone else surprised besides me that a Gleason 9 can have a PSA of almost undetectable after surgery alone?
Was the 4+5 confirmed or changed as a result of the post RP pathology?
It was confirmed, and I had the confirmation double checked, and
Okay.
the double check agreed.
And who double checked it for you?
Dr. Ming Zhao.
Okay. Okay. And
And I
confirmed
presume
you
you had some scanning, Steve, before they did the prostatectomy, and they didn't find did they find that it was completely within the capsule?
I did have a PSMA PET scan that came up negative, and the biopsy on the prostatectomy indicated focal extraprostatic extension. So they gave me a T3A instead of a T2A. I should say PT3A instead of PT2A.
but I'm assuming they took care of that with the surgery and there were no positive margins. Is that correct?
That's correct. The positives, there were no positive margins, no lymphatic or vascular invasion. Seminal vesicle invasion was not identified. Yeah, so it's just the extraprostatic extension.
No,
So
I agree with Len that especially as a T3A, to have nothing showing at 3 months is fabulous. I see Gary has his hand up. Go ahead, Mr. Peters.
Len, as
No.
you picked up on Rick, Len had said, is anyone else surprised? And I was just going to say, as a fellow Gleason 9, I'm very surprised and very envious.
yeah. Well, I guess they got that prostate out just in time before it had a chance to spread, as far as we know.
Yes, as far as we know.
So was that the limit of their detection, 0.01?
Yes, the report says less than 0.01, so I'm assuming that's the limit of their detection.
Okay.
Yeah, it's close enough for government work. Steve,
Yeah.
I think that that Steve Rubin has his hand up.
Go ahead, Steve.
Well, I did have my hand up, but you just answered the question. I thought initially he said less than 0.1, and then I was going to suggest maybe an ultra-sensitive PSA would be appropriate. Clarified it, so it is an excellent result for surgery with that Gleason.
Yeah.
Yeah. Looks like we're all in agreement on that, Steve. You're doing well.
Yeah.
Any other questions for us, or does anyone have any advice for Steve for questions for his
Tony
visit?
Fig has his hand up, Len.
Okay,
Steve,
Tony, go ahead.
Steve, did you have any germline testing done?
I did, yes.
Any results? Any positive results on that or indicators?
No, there were no positive results on it.
Well, I assume you would have absolutely no problem recommending Dr. Gerard again to anybody else. Did you?
No, and I kind of think
Yeah.
he's a bit of a genius. You know, when I first met with him, I asked him point blank if he could preserve the internal and external sphincters, and without any hesitation or hedging, he said yes. And I found out that he's done maybe 3,000 of these operations. And so and he actually followed up after I met with him first, and you know, he called me and asked how my journey was going and if I had made a decision. And so I think he's terrific. I think he's absolutely amazing.
Good. Well, it's good to know. You know, I'm not so strong on the urologists around the country, but we encounter people from all areas, and it's good to know that there's a really good guy in southern Wisconsin that we can send people to. So I'm sure Dr. John is making a note there for because he does some sterling work for us in the low intermediate group. Dr. John, not Dr. Gerard, but Dr. John.
Yeah, you know, back away before your prostatectomy, we encouraged you to run that MSK nomogram to see what it would predict about a prostatectomy. I'm curious now that we see what looks like a very good initial outcome. Did we ever do that back then?
I did run that, yes. I remember Rick sending me a link to that, and I did run that, and it didn't look very good.
It didn't?
No, after having met with 3 sets of doctors and weighing the pluses and minuses of the prostatectomy against the radiation therapy and hormone therapy, I kept leaning toward the prostatectomy, and that's what I decided to go with. So
yeah, good for you. So
roll the dice and whatever comes. You know.
I'm going to put Dr. Paul on the spot. Dr. Paul, how many 4+5s did you do surgery on who were undetectable after 90 days?
Well, it is, we've all said, a pretty unusual and happy outcome. And the pathology report, a little concerning with extra capsula, but still margin negative and appropriately read by an expert. So yeah, it like everything else, it happens, but not often.
Good.
Let me ask a
Stay
question.
vigilant.
Was there any discussion, just for curiosity, about the concern and maybe considering salvage radiation. That's not what I would have recommended, but did anybody bring that up because of the Gleason score and the extra capsule extension?
No, and I brought that up with Dr. Russell Schmulowitz because I had been down to see him, and he just said that the standard of care is to monitor the PSA and that's it.
Right.
So, Steve, you have no side effects. You're fully continent, capable of erections. I mean, everything was preserved.
As far as the erections go, I don't know yet. As far as urinary continence, I think I'm very good. I'm very pleased with it. I've leaked a little bit 4 times when standing up from a sitting position, but nothing that soaked through to my pants. It just dampened my underpants, and I was able to change quickly. And so now I'm just a little careful when I get up, but otherwise it's been very good. I've been very, very pleased.
Yeah, and you do the Kegel exercises.
I have done some, but not a lot.
Okay. All right. Okay if we move on, Steve, or do you have anything else for us?
Yes, Len, thank you very much. And just at the risk of wasting a little bit of time here, I heard you mention something about cataracts, and I'm going to be in need of cataract surgery, and I was just curious if you'd come across any good online cataract groups.
Oh, I didn't even look to see if there were any. You mean support groups?
Yeah.
No, I didn't even think to look for that. I think it's, for most people, it's so very straightforward that I'm not sure there's much of a need for support groups, but I mean, certainly I had no need for it.
Are you post?
Yes, only
surgery?
in the left eye. And the only issue I had was, which is not uncommon, I had an elevated IOP, intraocular pressure. It had gone up to 30, and then they gave me like glaucoma drops for that. And 10 days later, it was down to 7, and then I stopped taking the drops. So other than that, there were no other issues.
Good. Okay. Thank you.
Yep.
Thank you very much, everyone.
I just throw in a quick comment, not a support group, but a website. If you're interested in information about the different technology, the different lenses that are available. So there's a website called Cataract Coach. It's pretty intensely technical, but you can find videos. There's several thousand videos. You can find some that are more patient oriented about the different technologies choices.
Very good. Thank you, Craig.
You're welcome.
Are you on
I am,
Medicare,
yes.
Stephen? Okay, so you know that if you get the simple surgery, no frills, it won't cost you anything. But you can spend thousands of dollars if you go with some of the newer, supposedly more advanced lenses. My sister went with an advanced lens that was supposed to enable her to see both near and far, but she wasn't at all happy with it. She feels like she wasted $6,000.
Mm.
But
Yeah,
anyway,
that's one of the
questions
I'd like to get answered. I mean,
yeah, well, definitely ask your eye surgeon about that.
Can we interrupt this, and maybe we can come back to it at the end? Anybody who's interested we can get more into cataracts at the end, but let's at least get through men who need time. And we've also got quite a few new men who came in, and we may have time for them if they came in late, Len. So.
Sounds good to me. Okay. Dan Moore, you're up next.
First of all, I have one simple question. What is AnCan short for?
AnCan Foundation.
Yes.
Go ahead,
So,
Rick. You're the boss.
yeah, so originally when we started in 2016, our mission statement was that we wanted to provide virtual support groups for as many people as we could, and as many different conditions as we could. We were never really focused on just cancer, but we started in prostate cancer. The second cancer we went to was breast cancer. That didn't really take off. And I came up with this name, AnCan Foundation. And our URL was ancan.org. And then what happened over a period of 4 or 5 years was that we started moving into other conditions, including cancer, but also beyond cancer. And the first beyond cancer group that we started was MS, multiple sclerosis. And so once we got into multiple sclerosis and we got into mental health support and other things, I didn't want us to be totally identified with cancer. So we just went to our URL, which was AnCan, and became AnCan Foundation. And we actually legally changed our name and changed our name with the IRS. And so we went from being AnCan Foundation to AnCan.
Excellent, excellent. Now for something more serious. I had a PSA back in April. It was 0.5, and I had one yesterday, and it was 0.5, so there's no change. And I have to have a CAT scan at in a couple days. And so I wonder, is that the procedure is that the normal procedure?
Is your CAT scan for the prostate?
Yes.
Is it chest, abdomen, and pelvic region? Do you know?
Well, that's where my cancer is, but I'm not sure what it is.
I mean, typically that's what they would order, CAP,
Yeah.
chest, abdomen, pelvis. Well, at 0.5, do you know what your doubling time is for the PSA? What was your previous PSA value and how long ago?
Previously I had it in April. It was 0.5 also.
Oh, that's right. Did you ever have a PSMA PET scan?
Yes.
And when was that?
Let me just look for 1 second here. Come on. Missed it. That was on July 2021.
Okay. And was that at the time of diagnosis?
No, because I've been battling. My journey has been since 2014.
Oh,
Let's see, and my notes say the PSA doubled, and the PET scan. Okay, and it was bone scan. So I had a bone scan and a full body scan, and hormone therapy after that. So I'm not sure exactly what the PET scan revealed. I didn't write it down.
yeah. So what therapies have you had so far?
I've had ADT and radiation.
Okay. And currently, are you still on hormonal therapy or
Yes.
you are? And what are those What are those drugs? One or two?
Abiraterone, Lupron, and
Okay.
I think I'm going to have to go back on prednisone.
Oh, if you're on abiraterone, you should always be on prednisone.
Right. Yeah, because it was shooting my blood sugar up so high that they took me off it. And I asked them that question today, whether I should be back on the prednisone.
Well, maybe you should ask them to take you off abiraterone and try a different, what we call second line anti-androgen, either darolutamide or enzalutamide or apalutamide. We prefer darolutamide here because it doesn't penetrate the blood-brain barrier. So there's most guys perceive it to be less fatiguing.
Right. Okay.
And you won't have any issues with your blood pressure or your diabetes or blood sugar.
Right. Okay. So I asked her, where's my questions for Schlossberg? I asked them about darolutamide, and they said you have to take. They say it's short acting, so I would imagine I would have to take it more often.
That's twice a day.
Right. Okay. So the darolutamide would be in place of the Lupron.
No, it would replace the abiraterone.
Okay. Okay. All right.
And you don't need to take prednisone with it. So is this conversation with stopping the abiraterone my notes say that you didn't stop the abiraterone, but you stopped the prednisone because of your blood sugar issues. Was that under the guidance of Dr. McHugh at MSKCC, or was that under your local people?
Dr. McHugh didn't have any problem with it. He didn't mention it. And so, but it was under the local people.
So, Doctor, I'm just wondering, because it's so unusual that he would have just assumed that you were still taking, unless you pointed it out to him. I'm sure he would have thought you were taking prednisone.
Yeah.
Did you point out to him that you were taking abiraterone without prednisone?
In my conversation, I probably did.
Okay. I would definitely make sure that they're well aware of it. When are you seeing Dr. McHugh again?
I'm not. He asked me for my DEXA scan, so I sent that to him. That's the last time I had any contact with him.
So who's your quarterback right now?
Dr. Schlossberg with New York Oncology Hematology.
Right. As we said to you, you've got to get out from under that. If Dr. Schlossberg is prescribing abiraterone without prednisone, it would give me very great concern, and that's why we wanted you to move away. I don't think any of us here have ever heard that.
Yeah. Well, Dr. McHugh said, I'm getting this gold standard treatment, so. But I'll mention it to him so I can make sure that he knows.
I think you need to ask him if gold standard treatment is abiraterone without prednisone. I think you've got to be on top of this with him, because that's why we sent you there before.
Right.
And it's really concerning, because I don't know how long this has been going on. About a month, right? That you've been taking the abiraterone without the prednisone?
About a little more than a month.
I think you've got to be talking to somebody who really understands this stuff, and it doesn't sound like that's Dr. Schlossberg.
So let me ask you, why is the prednisone so important?
Because the abiraterone essentially puts your adrenals, the way that it works, it puts your adrenal glands to sleep. And so you need to supplement your adrenal glands. And the abiraterone and the prednisone supplements your adrenal glands. Now, if you seem to be doing fine, although have you lost any weight? And how's your appetite?
My appetite's good. I lost about 10 pounds, but that was intentional.
Well, again, I've got to pass it off to the physicians who are in this group, but there can be really severe consequences from not taking prednisone with your abiraterone. I mean, Dr. John or Dr. Poole or Dr. Russ, do any of you want to address that?
Well, I'll say you can skate along as you are without the prednisone for a while, but any insult that occurs, whether it's a bad cold or an accident or a fractured, any issue that requires your body to pump out steroids to maintain your blood pressure and all that, you really can get into trouble. Way in the beginning, our group lost a patient because of just this issue, didn't have a bracelet that said they were on prednisone and went to another hospital, had a significant illness and died of corticosteroid failure, basically. So yeah, it's something you should not be calm or tepid about pursuing.
Okay. Because I asked him today, and I haven't got an answer back. I told him what my blood sugar was, and I told him, I asked him, should I be on should I go on back on prednisone? And I haven't had an answer from him.
But this is Dr. Schlossberg, and I think we will stick by the advice that we gave you originally, which is you need a genitourinary medical oncologist running your care. Now, you can choose to ignore that.
Oh, no, the only thing about that was Dr. McHugh, signed off for him. So, I'm wondering if maybe.
Yeah, but we weren't sending you to Dr. McHugh for a second opinion, Dan. We were sending you to Dr. McHugh to take over your care. We weren't sending you there for a second opinion. We don't think that any man with advanced prostate cancer should be supervised by a doctor who's not a genitourinary medical oncologist. And my concern is that Dr. McHugh may not have realized you weren't on prednisone, because he is a very good doctor.
Right, yeah.
And if he didn't, and he said you were on gold standard, it doesn't make sense to me. If he didn't say to you, go back and talk to Dr. Schlossberg about getting back on prednisone, or he didn't talk to you about switching, which is a very good suggestion. If you have issues with your blood sugar, then you'd be a good candidate to switch. I don't think he recognized all the facts or noticed that you weren't on prednisone. It never happens. We just don't see men on abiraterone who are not on prednisone as well. Now, or on a corticosteroid, it could be dexamethasone, it could be prednisone, but they're on some dose and some level of steroid supplement. And this is, I just want to say, in my view, I'm not a doc, but I would consider this to be serious, and it needs to be addressed sooner rather than later with a solid genitourinary medical oncologist like Dr. McHugh. If you write to, I mean, you have access now to the portal. If you write, you need to write to Dr. McHugh. This is, well, you don't need to do anything, but this is what I would do. I would write to Dr. McHugh and I would say, Dr. McHugh, you said I was getting gold standard treatment. Were you aware that I've been taken off prednisone and for the last 4 weeks and I'm still on abiraterone? Do you consider that to be gold standard treatment?
Right.
And then I probably would say, do you think that maybe I should be switching my ARSI or ARPI, same thing, or second line anti-androgen?
Okay.
Yeah, Dan, I think it's pretty safe to assume, as I'm sure we all do here, that he does not know you're not taking prednisone with abiraterone. He would not be happy at all to hear that.
Okay.
So you have to bring it to his attention.
Okay. Okay.
Dan, do you need us to write any of this down?
Yeah.
Maybe one of us can send you a text or an email.
Okay.
And write it down. And if you get anything like a lot of weakness or fatigue or stomach problems, skin changes, dizziness, then you must act right away.
Okay.
This has to be done now. I thought a month ago, when you first told us about your difficulties with abiraterone, I thought you had been taken off it way back then.
No.
Okay.
Yeah, I mean, I didn't think that, John, at least in my notes. I knew that he'd been stopped, but what we said is you got to get yourself over to a new doc as quickly as you can, because that was a sign to me that this doc doesn't understand prostate cancer.
Right.
But if one of you guys can follow up and or reach out to us if you need us, but. Yeah, I hope we're leaving you with a sense of urgency here. Dennis, do you have your hand up?
Yeah, quickly, when you did stop taking that, did you?
It was at least a month ago.
Did you wean off of it slowly, or did you just stop taking it?
Just stopped.
Yeah, but he'd hardly been on it, Dennis.
Oh.
Yeah.
He'd been on it for a couple of weeks, something like that.
Okay, I thought it was on longer. Okay.
And do you have an appointment with McHugh anytime soon?
He was gonna go over my records, and the bone scan. That was about it. So.
And I'd be happy to be teleconferenced in to your next appointment, if to help explain and help you understand, the message from the doctor. But of course,
can you find
have
out when your next appointment is?
From Dr. Q? Yeah.
Yeah. I mean, find out tonight while we're in group and let us know.
Yeah. Okay. All right.
If it's possible. Then if it's soon, Len can join you and we can get this all fixed up.
Yeah, I just recently did that with another oncologist at MSK. I was teleconferenced in. They're very cooperative in doing that.
Well, that's because they know Len. He's done it with quite a few of them over the years. And they say, oh, it's Dr. Sierra again.
Can't get rid of that guy. Okay. Dan, we're going to move on if it's okay with you.
Yes. Also too, they told me that magnesium works well for hot flashes. And,
I don't believe I've heard that.
No,
I mean, I suppose it will help some people.
Yeah. I haven't heard that one.
No, okay.
Maybe.
If you're having issues with hot flashes, and maybe we can come back to this at the end in case we do have some suggestions for you, and see what Dr. McHugh says. There are some non-invasive treatments. There are some integrative treatments, and then there are also some pharmaceutical treatments as well. We suggest you'd start with the non-pharmaceutical treatments and supplements, but I'm not familiar with magnesium. I don't know. Anybody else heard of magnesium supplement being suggested to combat hot flashes?
I've heard it used for muscle cramps, but not hot flashes.
Yeah, muscle cramps and restless leg syndrome, but not hot flashes. I've not heard that.
Yeah.
Yeah.
All right.
Yes, here it is. Okay.
We'll come back to you in a minute, Dan, after we've been through the next person, give you some time.
All right. So, Al Latimer, you are up.
Well, hello, everyone. Rick, I sent you my most recent numbers from last week, and
Right.
you can see I'm having a really good response to the current quintuple therapy that I'm on. But the thing is, this is not going to go on. This can't go on indefinitely. Something's going to happen, and I need a plan going forward. And one of the things you mentioned was that you had talked to Dr. Amigal about getting me actinium. And I first kind of poo-pooed it, but I'm at a point now where I think I'd like to at least investigate it. I've talked to Dr. Scholes about this. He has given me a name of a doctor in Istanbul, which seems a little distant to me. But that's on the table also. I have not had a heart-to-heart with Belusic yet. I see him in a week or two, and obviously I'm going to discuss that with him. And but right now my PSA is going down, so I'm feeling a little relieved about it. Anyway, that was the gist of my question to you, Rick, whether you had mentioned Amigal, and I wanted to follow up that with you.
Right. When I saw Dr. Almiguel at PCRI, because he was there, I pulled him aside. We went over and sat at a table. This was during the PCRI reception. And we talked at some length about your situation. And he said to me that he's just found a way to obtain an alpha. I think it was actinium, but it may have been another alpha particle. I honestly cannot remember, and I cannot remember what he was pairing it with. But he had found a way to deliver. I'm pretty certain it was PSMA-based alpha, and it was going to run about $18,000 a treatment, which is probably comparable to what they want to charge in Turkey, I'm guessing. And that he would be very willing to work with you on that. So that's what I brought back to you. And I think that if that's where you want to go, he did suggest that the three of us could talk, although I'm not sure that's really need me in it, but that's what I bring back as the messenger. I to be honest, I can't remember now exactly what radionuclide therapy it was, but it was definitely an alpha particle therapy.
Okay,
other
so
thing,
yeah,
go ahead.
I was going to say, so then I should email him to get this going, or phone call him, or I would like to have you you kind of looking over my shoulder, since you have a lot of expertise in all this.
Yeah,
So
I
I
mean, what
wonder.
I would suggest, call his office and say that that Rick Davis from AnCan Foundation followed up with you pursuant to the conversation at the PCRI conference, and that you'd like to set up a conversation about possibly doing alpha particle treatment, PSMA treatment in Miami, and to set up a time. From just from my standpoint, please don't make it before 8:30.
8:30 your time?
8:30 my time, and my time is changing next week. So after November 2nd, I'm going to be 2 hours behind you and not 3 hours behind you.
I see, because you don't go to daily, you don't go to standard time then.
We're always on standard time.
Oh, you're always on standard time. The opposite.
Yes.
Okay. I
Yes.
see. You're always standard.
We're always standard. We're very standard people here in Arizona, and and so yes, so set up a time. I'm available most mornings from 8:30 onwards. That's usually the best time. Sundays, Wednesdays, I often have a seminar that starts at 9, but that's what I would suggest. Now, for those who are wondering, well, how well is Mr. Latimer doing? The first thing I want to say is don't set your standards by Al Latimer's standards, whatever you do. Because these numbers are going to astonish you. But the fact is that Al Latimer is a gent who makes a lot of PSA, huge amounts of PSA, very unusual. So Al goes along for months, if not years at a time, at PSA levels around 100 to 200. And he does just fine that way. Now, his PSA did go all the way up to 755 just recently, like September or so. And then he started doing docetaxel and carboplatin along with Dr. Belusic, and it's come down from that 755 to 531, which is like a 30% drop. And it wouldn't surprise me if next time he says, oh, my PSA is down to 250, because that's what happens with him. But these are not, this is what's the phrase they use for it? For this type of prostate cancer now, other than unusual. There's a medical term now they have for these prostate cancers that either make no PSA or very high PSA or what have you, and that's we could actually variant. Thank you, Lynn. Variant PSA is what variant prostate cancer is what I was going to say. We could actually call it Latimer prostate cancer. Maybe we'll coin a term for it. Ask Belusic if he wants to try and coin Latimer for people like you.
So you're saying I'm a freak, is what you're saying?
Yes, exactly.
So I was talking with.
You're a freak that we're trying to keep in the US for your treatment. If you are willing to consider spending that sort of money for a treatment, as I've said to you, I think we can do just a good job here as you can in Germany or in Turkey or in Australia. probably at a comparable cost. So,
Well,
Len,
well,
go
I
ahead.
No, I had nothing, Rick. Well,
Rick, I was just
unless
gonna
you
say,
want
go
you want to
ahead.
give the rest of us an update on where you are right now, Al, because apparently you've been communicating with Rick privately.
Well,
Just
he gave,
like briefly.
well, just to back up one step, my PSA had been in the 100 range, and then I got other problems, and I went off therapy for 4 months, and so during that period of time, my PSA skyrocketed, and then once I was able to get it back on it again, I added carboplatin and Abby to this, and the three of those together. Plus, I'm already on dutasteride, and I have no testosterone, so I really have kind of a quintuplet therapy right now. And right now I just had therapy last Friday, and so I'm kind of at a low point right now with energy, but that will improve as the days go on. And I really don't have any other problems. I have zero pain from all this. Never have had any pain. So I'm back into this freakish mode again. I can't really explain it. The other thing is that I've been doing this for 30 years. I mean, I was diagnosed 30 years ago. So just, it's bizarre. I don't know.
Larry Peters, go ahead.
Al, when your PSA was way up high, did you happen to have anything like a PSMA scan to show where the cancer was?
Well, not at that point, but somewhere in that process. So it's in the lymph nodes. It's in. I have some in my spine. It's in a number of places.
Well, it's great that it's come down that much.
But I mean, I was hoping for at least to stabilize the increase, but I've had a really good response from it, and like Rick says, I may come back down to 200. Who knows? But I don't know. One thing or another is going to happen eventually. That either whatever cancer is left is going to stop responding, or the side effects are going to start to overwhelm me, and I'm going to have to look for something else. So that's kind of that's kind of where I am right now. But I never would have dreamed I'd have a PSA of even 500. I mean, it's just crazy. But I guess, like Rick says, I'm just a PSA manufacturer and always have been. And here I am. I'm still here.
Yeah. Have you talked to Dr. Belusic about updating your somatic testing?
No, but I see him actually, I'm going to send him an email ahead of time or a message through UM about that. And he's already scheduled me for another PSMA PET in another month. And also I haven't talked to him if he has any other tools on his table that he might like to anticipate for the future. I have not had that discussion with him yet.
Well, one of the reasons why I think that you need, and we mentioned this to you last time, to get that somatic testing is because that if there is something that's emerged, then that might give a clue to a precision medicine alternative to the alpha.
Yes, I agree with that, and I will get that done.
Well, guys, Al was the last one I had on my list, and I know a bunch of you came a bit late. So if there's anyone who came late who would like some time, just let me know. Oh, Phil, I'm sorry. I didn't get to you yet, Phil. Go ahead, Phil.
Okay. Really, I haven't talked much with you. I listened some, but I'm getting ready to figure out what I'm going to do. My journey, I think, started compared to 30 years ago. Nothing like that. Mine started April of last year, and where my PSA jumped and my primary sent me to a urologist, and they did the biopsy, came back 4.5 Gleason, and I think at that time my PSA had jumped to 16 before I went. And through my friend Don Rogers, who I think may be in Italy right now, but anyway, he turned me on to Mario down in Miami, Dr. Belusic, and I started off with I never pronounce it, the Nebeka darolutamide and Lupron, and he suggested that we had a talk, and he said, I see him just once in a while face to face. A lot of times it's tele up here.
Done.
Huh? Anyway, I go see him, and when I went to see him, I had done a PSMA. I think when they did the biopsy, it was something like 6 cores. And then I went to get a PSMA, and it turned out that it showed, that's before I went to see him, and it showed stage 4, and it had a lesion in the left shoulder. Other than that, I went and he asked if I wanted to try chemo, and I did chemo, and he scheduled me for 6. At number 5, I had side effects. My temperature went up to 104, and then I went in the emergency room, and in the emergency room, they managed to give me antibiotics to hurt my liver or kidney or something. They got that stopped. And he said, I don't think you need to go to number 6. So at that point, we went down and did a couple more things with Belusic staying on the Lupron and the Nebeka. And he told me in September, my PSA has been running about 0.04. My last one ran 0.02. And he was saying he's thinking about that I go off of everything. And I told him I was a little reluctant. I wanted to do the next PSMA and see if we're on. And in the time, I had a shoulder problem, rotator cuff, and I said, well, he said he wanted to get a with contrast MRI. And surprisingly, when the MRI came back, all the other times with the PSMA, the bone one was stable. This time, after the chemo, it came back. There is no vision of a lesion in my shoulder. So now we're thinking about going off, and I'm thinking I have one more PSMA in December, and if it stays the same, I'm going to take them up on it and go off. I just didn't know what y'all think. It's been a good, as the gentleman was saying, it's an incredible trip with Dr. Belusic. And my friend in New York, I see them when they go on cruises. I have dinner with Dr. Slovak, and that's a good thing.
Yeah.
That's it.
And by the way, if I'm not mistaken, Mr. Latimer is a neighbor of yours.
No. I'm in Vero Beach.
Vero Beach. And where are you, Al? You're a little further north, aren't you? Oh, he's just. We'll have to wait until he comes back in. He just.
Oh yeah, I see him down there. He went somewhere.
Yeah, he just.
Yep.
Where are
Okay,
you?
well, I was on a side trip. Yes, Port St. Lucie, just south of Vero Beach.
Yeah, you're 30 minutes from me. Yeah.
That's what I
I'm in
thought. I
South
thought
Vero
you guys.
Beach.
Okay, well, you guys need to get together for an AnCan coffee.
Okay,
We'll do that.
Well, Phil, that sounds like a good idea. I'll send you my phone number.
Okay.
We can figure something out. So.
Yeah.
I go by you all the way to Deerfield. I go by you on the way to Deerfield.
Oh, well, we could go to Deerfield together.
Yeah.
I go to Deerfield every 3 weeks right now.
There you go.
God bless.
So, we'll either call it an AnCan coffee or the Belusic boys. So
either one. He's really good.
Go ahead, Dr. John.
Go ahead.
So what do you think? You think if it comes up clean, I ought to go on holiday?
Dr. John, go ahead.
How long have you been on ADT? And
Been on it starting, I think it was June or July of last year. I went on to Nubeqa first, then in July I got my first Lupron shot. I'm scheduled for another Lupron shot, of course, in January.
And what was your Gleason score?
4.5.
4.5. I think you should give yourself at least 2 years on ADT before taking a holiday. At least.
Okay. Well,
I did 2 years.
Well, we're a year. Well, then December will be a year and a half.
All right. It's up to you, but I wasn't a 4.5. I was a 3.4 22 years ago. And
wow.
And I get myself 2 years. Close to 2 years. With Belushi.
Okay. Okay. Good.
Just my opinion. See what he has to say.
All right, John.
Anything else other than that? That's all I have.
John, we're not hearing your voice.
We were hearing you fine, John.
Yeah, all of a sudden.
Yes. Something happened with that. So whilst John's getting himself fixed up here, he's putting his earphones on. Anybody else have any thoughts on 18 versus a longer period of time before going on intermittent? I mean, I think most of us at AnCan are relatively supportive of intermittent therapy. We don't like to hear doctors coming back and saying you're going to be on hormone therapy for the rest of your life. And we do hear that, and we have heard that. And even some of the doctors we like have said that. So when we find a doctor who's willing to consider intermittent therapy relatively early on, that's very good. The question is how early on. And as you heard from Dr. Jack, you know, the maybe 18 months is a little bit early. I tend to think also probably stay on for 2 years to begin with. Phil, did you have, I can't remember, did you have any type of radiation or not?
On the shoulder?
No, on the prostate.
Oh, no radiation. We went straight to chemo, and it was great for 4 times, except I got bald. And
okay. So I think one of the things that I'd be talking to Dr. Belusic about right now, maybe before you go off the hormone therapy, is what does he think about debulking the prostate? What about radiation therapy to the prostate?
Okay.
I think that's a legitimate conversation today, because a lot of men who are de novo metastatic don't do that, don't do any sort of debulking, usually radiation, occasionally surgery, but they don't do it up front. Having said that, a lot of the men do go back and they do visit that, because we seem to think that it gives a more lasting, durable response. So that's definitely something to talk about. John, can we hear you yet?
No.
No. What's going on? Make sure we got the right microphone there, Dr. John. Anybody else want to talk about 18 months, 24 months, or debulking? Anybody have any experience here with they were de novo metastatic and they went in later and they radiated the prostate? Do we have anybody that fits that bill in this group right now?
I kind of fit that, Rick. I was also a 4+5. I had metastases to the pelvic lymph nodes on diagnosis. And this is 2014 when PSMA PET wasn't available. I wouldn't be surprised if I had some bone micrometastases at that time, but we only had the more primitive conventional imaging. And kind of like you, I was put on only hormonal therapy. And even at that, it was only intermittent hormonal therapy for 18 months before I finally switched oncologist, and the new oncologist said, yes, you should definitely debulk the prostate with radiation, because it looks like you're about to become castrate resistant. So I took his advice. I had the radiation to the prostate, and that brought it down to the lowest level ever, which was 0.1 at that point. And I've had multiple intermittent or drug holidays, let's say, multiple intermittent ADT therapies since then.
Okay.
So it's a little bit like yours, a little different. I never had chemo. You never had radiation, but I like Rick's advice to debulk the prostate. It makes sense to me.
Okay, I think Dr. John chatted in that he agrees that I should maybe take a look at it. I don't see him shaking his head, but I have one other question. Any other?
Can we hear John? Let's check again. Can we hear John? Come in, Dr. John. Yes. Yes.
Oh,
yes.
Okay. I don't know what I did differently, but anyway, I texted my comments in. I have always been unhappy that radiation hasn't been part of Phil's treatment. And
wow, okay.
So talking about de-intensifying does not make me happy, especially de-intensifying a little on the early side.
Okay. All right, I'll talk to him right away about that. I have one last question that came up earlier. I'm on the Nubeqa, but for some reason he's left me on prednisone. Is there any reason I should stay on prednisone?
No, not unless there's some other reason he put you on it.
No, I think he put it on me when I was having the chemo.
Yeah.
I did ask him, but
ask him if you can taper it off nice and slowly.
Okay. All right, I'll bring up those two issues.
When your chemo finished in May, right? It's a good fun. So yeah, I mean, Gary, we'll bring Gary in on this one, but be very, very sure that you come off, that you wean off slowly. Gary, you wanna talk about weaning off slowly for Phil?
Yeah. The longer you've been on prednisone, the more important it is to stretch out your you're leaving prednisone.
Okay.
And you can look on Dr. Google under long weaning program.
Okay.
Some people get away with doing it short, but if you're not one of those people and it's too short, you can have a lot of trouble. You may be on a steroid forever.
Yeah, I agree with you. I had a doctor throw some away, but got mad at me a long time when I had a dose pack way back when. He really got upset with me. I discontinued the dose pack. So I know the problems, and thank you for the advice. And I'll certainly get a long weaning off of it. I want to get off of it. I didn't know. So that's good. Good point brought up tonight. Thank you all. Well, that's it. I got questions for Dr. Belusic, and I got to figure out how to stop in Port St. Lucie and visit my comrade there. Comrade in medicine, not anything else. Thank y'all.
Did you have a question again, Gary?
I did for you and Len. what is the thought process in determining when it's a good idea to debulk the prostate?
Well,
Like,
in
why
most
do you-
cases, in most cases, it applies where somebody is de novo metastatic, because it's unusual that you don't get a primary intervention. If you're not de novo metastatic, if you you're going to get some sort of primary intervention unless you're aged and just going on hormone therapy. So we're really only talking about people who are in a de novo metastatic situation. Can be oligo, but you know, a lot of times they'll treat oligo people with radiation early on anyway. If you've just got 2 or 3 spots and we're seeing that with some, I can't think who it is right now, but they're talking about treating the prostate and adding 2 or 3 sessions of spot radiation at the same time. But more often it happens where somebody has multiple Mets, extensive Mets early on, and they go straight into chemo. And then we talk later about, well, maybe you need to debulk, which is Phil's situation. And I think probably there are other people on here, or if they're not, we have plenty. And that's where the consideration comes in. And then the question is, do you or don't you talk about it? And it's usually about this time. You're about a year and a half out. What we have heard from most of the good GU medical oncologists is that they consider it to be a good practice. The evidence, I don't think, is that strong, though. So, you know, you talk to some of the people who go strictly by the book, and they might say, no, don't do it. John?
I'm sorry, I stepped away for a minute. Are you still talking about debulking?
Yes.
Yes.
If the person has local symptoms, you know, like pain or urinary problems, then debulking seems like a good idea, even in a situation of metastatic disease. And when you look at how they do afterwards, people with low metastatic burden did well after debulking, but people with high metastatic burden didn't benefit from it.
That's right. I remember that now.
Thank you.
So, Len, do we have anybody else who came in late who'd like some time?
Well,
anybody?
that was my question before
Yes.
I remembered that Phil hadn't gone yet. But Phil was my last.
That's okay.
But Phil was my last one. So if anyone else has would like to request some time, now let me know.
This doesn't happen, guys. So, you know, take your chances whilst you can. It's a good night tonight.
Let me
Hey,
share
Jack.
something. I was an hour late because I just finished listening to CARIS's lecture on mutations and their whole thing. I was interested in particular because of the chip mutation. They did a whole thing about, you know, how they can differentiate between chip mutations that are, you know, actionable and ones that are not actionable but interfere and cause false positives. And you end up with treatment when you don't need it. So I want to recommend it to any of you who haven't. It's recorded, and it's part 3 of the CARIS lecture on whatever it is, whatever it's called. liquid
Okay.
biopsy. Yeah, but it's really good.
Okay.
Okay,
And you've got
thanks,
a
Joe.
couple of hands up now, Len.
So we do. Let's see. Bruce, go ahead.
Thanks. I've been on Orgovyx for about a year, and my legs and my upper thighs are aching like hell. And I'm just wondering if that is one of the side effects of Orgovyx.
I think it's a side effect of any ADT drug. Joint pain, muscle aches. And what else did you say you had?
That's basically been about it. I've had to go to relying on a cane in order to get around.
Did you
Are you
have
by
a
any chance
prostatectomy?
taking a statin?
No.
Okay. I think I interrupted you, John. Go ahead.
No, I think I interrupted you. Sorry. Did you have a prostatectomy, Bruce? I don't remember.
No, I had radiation.
Okay. Do you still get lymphedema?
Very, very mild. It has not been a serious problem. The doctors have suggested, but so far I've gotten by without those socks, compression socks.
So, one thing that might be appropriate here to talk to your doc about is maybe you would be a candidate for magnesium.
Oh.
That, as we talked about before, for the muscle pains, is it just pain or is it cramping as well?
No, just pain.
I don't know, docs. We got a bunch of these docs on here. What any thoughts on supplements for and most of you have been on ADT, so any thoughts to help Bruce?
I say a careful physical exam first.
Okay.
Well, I can get that done.
Have you tried Advil? Does that help any?
I've been sometimes when this first started, I took ibuprofen, and that helped.
Okay.
But not the other one.
Okay, and are you still using ibuprofen?
No, actually, I thought about taking a tablet this morning, but I didn't.
So, I mean, again, if it were me, that would be my go-to. I don't use a lot of ibuprofen, but I probably take it 3 or 4 times a week.
It looks
especially when I get up in the morning and my back is really stiff, which happens quite often, but I'm exercising quite a bit. But I do get sore from the exercising, and I do use the ibuprofen, and I happen to go with 1 pill at a time. I don't take 800, I take 400s, and then if I find I need another one, I'll add it. I tolerate it very well.
Yeah, whenever I've taken it, it was the 400, and I only take 1 pill.
Okay.
And that seems to solve the problem.
Well, maybe we solve the problem right for you. Stay on that ADT and see how you do with a couple of ibuprofens every once in a while.
Okay, I appreciate that.
That was a who suggested the old ibuprofen there? Was that Dr. John? But whoever said it, thank you very much.
That was the Fratello.
Oh, they're very good. Good job, Len. Good job. Good job. See, that's why those MSKCC doctors like to have you in the room.
Okay, Dan, we were going to circle back to you. What have you got for us, Dan?
I couldn't get a hold of him, but I leave a message on his voicemail and just made sure he knew that I wasn't on prednisone. And I asked if he would call me back and just let me know his thoughts on that. And initially, when we talked to him, my wife and I, he wasn't that concerned that I hadn't had the Candace shot before I had the Lupron. And he just wasn't concerned about that. He seemed to say that was not an issue. So,
Well, look, here's the thing. It's not an issue because you got away with it, but it isn't standard practice. If he was putting somebody, if Dr. McHugh was putting somebody on Lupron, he'd put them on bicalutamide first, or he'd give them Orgovix or Firmagon.
mm-hmm.
He wasn't that concerned it didn't happen because there was nothing bad. I understand that, but he wouldn't do that. I'm sure. The other thing is you need to put it in the portal. Don't just leave a message. You need to go into your MSKCC portal.
Yes.
And whatever you said,
tried that, but I
put it in there. You
I
can't get
tried
into
that.
the portal?
I can't for some reason.
Well, again, call MSKCC tomorrow, because the reason I say that is when you call, we don't know how it gets transcribed. When you put it in the portal, it goes in your record there.
Right, okay.
Okay, so if you're having trouble getting into the portal, it's probably too late now to call MSKCC, but I'll tell them you're having trouble getting into the portal, and
okay, I'm in now. So I'll send
okay.
that message. Yes.
So now that you're in, just put that in there. That what we've suggested you say, that he needs to know you're not on prednisone, you're taking abiraterone, and does he consider that? You mentioned that was gold standard. Does he consider no prednisone to be gold standard? And what does he think you should be doing about this?
Okay.
And the guys will help you. Len's available to help you. So Len at AnCan.org, reach out to him.
All right, Jeff Markey and then Jack. Go ahead, Jeff.
Spray on magnesium is supposed to help with leg cramps and leg pains from spasms. Spray on magnesium. Also, a palliative care doctor would be a good person to go to if that's something we've already recommended doesn't work.
Is Dennis Correa still with us?
Yeah, I'm here. TheraWorks.
TheraWorks.
TheraWorks, right.
TheraWorks.
You still swear by that?
Mr. TheraWorks.
TheraWorks.
The main ingredient is magnesium. That's the main thing is magnesium, type of magnesium.
Okay, what we're saying, because Bruce probably didn't get it, is we're talking about TheraWorks, which I just put in the chat for you, Bruce. TheraWorks. And that is a spray on magnesium that Dennis Correa swears by.
And I do too.
I never go anywhere without it.
However, I was a non-responder. I have to come clean on that. Jack, go ahead.
Well, this is, you were just talking a few minutes ago, and that's when I raised my hand about ibuprofen. And I took ibuprofen for years when I played golf. And that's before I started the ADT. And then when I read and I spoke to people about ADT in terms of what it does to your lipids and the potential for coagulopathy and all kinds of other problems, I didn't want to gamble on it. So I was willing to live with the pain, which has been pretty brutal on the ADT and really limiting me in lots of ways. But I didn't want to gamble on closing off my arteries. maybe Rick, one a day isn't too bad to take from time to time, but I was taking 1 to 2 and maybe 3 times a week because it would loosen me up and take a lot of pain away from the golf game and my shoulders and everything else it would. And so I, what's the matter? Somebody interrupted? Well, okay, well, that's what I had to say. So it's a trade-off, and I decided to, err on the side of caution against my heart because I've over and over heard the thing that really does you in this journey we're on is the cardiovascular complications induced by the various medications we take, and I try to be conservative with that because I believed it. And I had it corroborated by my medical oncologist. So I lie low on ibuprofen and Aleve and those other things that potentiate the coagulation effect. And I just had my lipids fractionated, and I've had perfect lipids for years. And low testosterone really messes up the very low density lipids. You do the microfractions, and it's kind of scary. So as testosterone comes back, that all re-regulates. So that's the hope I have, that would happen in time, but who knows what's going to happen.
Okay, thank you, Jack.
Yes, sir.
Anyone else have anything they want to contribute? I can just very quickly state, some people may remember my testosterone was slowly drifting down, even though I was on a drug holiday, got to as low, I thought it went to 99. I looked back and it went as low as 79. And yet, for some unknown reason, the last PSA test I had about a week ago, it had doubled to 160 from 79. Who knows why? I'm still on drug holiday, but all of a sudden it jumped up.
Wait, you said your PSA doubled or your testosterone doubled?
Testosterone.
That's good.
Yeah.
And
I don't know if it was
good.
I don't know if it was psychological, but I actually did feel better, like exercising and such. But I mean, 160 is still on the low side, but I'll take it.
And your PSA is changed.
PSA is stable at 0.05.
That's great.
Yep. No complaints.
Maybe it was the psilocybin, Len.
Yeah.
What do you think, huh?
I think maybe so. Can't wait for my next dose.
Sure.
All right. Well,
Rick.
I will say, I don't, I know most of you in this group did not know Ken Mason, because whilst he had 4 different cancers, God bless him, none of them ever really got out of hand, and he was able to do minimal therapy for his prostate cancer, his bladder cancer, his kidney cancer, and his colon cancer. But if you ever attended Men Speaking Freely, you certainly would have known him, if for no other reason that he had the worst jokes on the planet. And he insisted on telling one every time, either at the beginning or at the end. We loved him. He was an incredible guy, and I feel very fortunate that he came into my orbit. And the only person, the next person after him that I've been supporting as long as him is Len, because I think Ken actually started in our meetings before Len did. And so I was fortunate enough to go to his celebration of life over the weekend in Lincoln, Nebraska, where he lived with his husband of 45 years, who was the dean of the former dean of the School of Journalism at the University of Nebraska, and it was it was a wonderful event. It was lovely. It was lively. The food was good. There were a lot of people from all over the United States, from Seattle to Miami. So, and all points of call in between. It is available to listen to. I think it's ken-mason.com. I think that's the website. We'll put it in the reminders. But and I know Dr. John was able to join virtually. Bill Franklin and myself were there. Howard Walensky also was there. And then I also had the great pleasure to meet with our lead moderator from our MS group, who I've been working with for 5 or 6 years and have never met before because she lives in Des Moines. So she drove the 2.5, 3 hours from Des Moines to Lincoln. And so Bill and I hung out with Kim, and that was just a real pleasure too. So yeah, I mean, I'll miss, and the irony, just going back to Len, is that Mason had been debating. He insisted on I used to call him Ken, but he insisted on calling himself Mason in support groups. And this was, I didn't even know this, but this Mason thing came out of him starting to go to support groups in the early 2000 teens. And he preferred himself to be known as Mason. And that came from him putting Mason on his coffee cup at Starbucks every morning. And he procrastinated about psilocybin for many months, if not years. He lived with depression most of his life, and he was going through a rough time, and he felt the psilocybin could help him, and he talked to us about it in the group, in the Men Speaking Freely. And finally, he booked a retreat in Colorado for mental health and meditation and yoga. And he went out there and he did 3 doses of psilocybin. He was comfortable with it. He said he felt a lot of love because somebody asked him that the morning that he passed away, or the morning he had his first stroke, and he had a stroke. They found a bunch of embolisms in his chest. We don't really know from what. And then very soon after he had that first stroke, he had a second major stroke. And so he went very, very quickly post psilocybin, which we think was a good experience for him. And so God bless him. I mean, his memory will always be a blessing for me. And I'll always laugh when I think about him, however bad his jokes were.
Rick, did he have high blood pressure? Do you know?
I can't remember. I don't think so. John, do you know? Did Mason have? Do you know? I don't think so.
That would actually be a contraindication for psilocybin because it does increase your blood pressure. Mine went as high as 168.
Wow.
Mine is normally about 100. The top number.
He had no history of arrhythmias of any kind?
I don't think so.
Atrial fib or anything? He wasn't.
No, I don't think so. I'll read. I don't know. I've got this really nice piece that Gary wrote, and I'll look through it again and just see. But I don't think so. But he was. I don't know. I mean, I wish somebody would have asked him that question all the times he talked to us in Men Speaking Freely about should he do psilocybin or not, because he did ask us more than once, right, Dr. Jack and Dr. John?
Yeah, he mentioned it. I just said if he did, I wanted him to be under medical supervision.
Which I think he was there. I think
Yeah.
this retreat was under, I'm pretty certain the retreat was under medical supervision. So, yes.
Hey, Rick, the
Yes,
audio kept breaking up, especially on really critical words people were saying. It was very frustrating to listen to it online. I don't know if other people noticed that, but it was frustrating. People would come say a really critical thing, and the audio would just go away for
I'm
that
sorry
moment.
about that. Did you find that, John?
I did have some, I characterized the audio quality to Rick as 80 or 85%. I lost a number of words here and there also, especially when somebody was talking rapidly.
So I know that they had some professionals doing that, and maybe when it gets transferred onto the website, they'll enhance the audio. Can't say for sure, but maybe. Sorry. I mean, I will tell you that even in the room, there were people who spoke softly, and we didn't hear them clearly even in the room. So, and we had to remind people to speak into the microphone. Hopefully you heard what I said, but that was it. All right, guys. Good night, everybody.
Night. Thank you.
Good night. Good
All right,
night.
thank you.
Good night,
Good
thanks.
night, everybody. Thanks,
you.
Lynn.
Don't forget, it's veterans speaking freely. If you're a vet, go over to Veterans Speaking Freely. Good night.
Peace, love, everyone.
Peace and love.